All right, so let me just go in the Facebook group and make sure. Okay, good. We are live. Perfect. Okay, so let me make sure my audio is coming through. Okay, good. Yes. Good. All right, so I would love for anyone who is watching this presentation, if you can jump on to the comments and add any questions, because I think this is such an important topic and there's so much confusion around it. And I think anyone who has a quick question and can add that to the conversation of the presentation today be so valuable, because I think a lot of us just have different perspectives or different um, areas where we might be a little bit confused. So adding your part to this conversation is really helpful, especially since I'm presenting solo today. I don't have Ashley on here with me, but I'm very excited to share all of this information because I find this whole world of imaging and screening to be very, very confusing. There's a lot of research out there on all the different types, and we don't really have the best overview comparing all of them side by side. Um, so I'm going to do my best because I did have to spend hours and hours of research on this presentation, and I've been doing thermography for 15 years. So I have been, kind of absorbing a lot of research, case studies, firsthand experience with thousands of different patients coming into our office. So it's not something that I find easily understandable if you're new to this conversation. And so I think adding my more experienced knowledge background to this conversation would be really, really valuable today. So jump in with any questions if you can, and let's get started. So the first thing I wanted to share is what we're going to talk about. And, because this is kind of I would say 45-minute to an hour talk, like there's only so much, unfortunately, that I can get into on all of these things. But I'm going to do my absolute best to cover information on mammograms, thermograms, ultrasound, fluid tests, which are a little newer to the mix, and MRI as well. So with mammograms, there are definitely some positives to it. You know, they're very easily accessible. They're covered by the Affordable Care Act. A lot of women should be able to access mammograms. It's covered by insurance, and it's widely accepted by doctors. I don't know any doctors that, wouldn't look at a mammogram. So that is a definite pro for sure. And I did have a little caveat with the covered by insurance because unfortunately I had a patient in recently and she had breast cancer last year. And so ever since she had her lumpectomy, they now are telling her she needs to have a diagnostic mammogram and ultrasound. And insurance unfortunately doesn't cover that. And I said, that is bizarre. Why? That doesn't make any sense. So she's having to consider, $2,200 for her diagnostic mammogram and ultrasound every year for continued screening. And so it is covered by insurance for like a screening mammogram, but then there's different scenarios that may cause a different situation to arise financially. So it can vary by situation. Mammograms are really good at seeing microcalcifications. So that's like a tiny little deposit of calcium. And a lot of them are benign, but there are certain ways that they can be distributed in the breast tissue that can basically be a little bit more alarming for malignancy. And so that can help detect earlier stages of breast cancer that might be missed by other imaging. So, and we'll go over some of that a bit more. And then they tend to catch more slow growing tumors. So there's strengths and weaknesses with every single type of breast imaging. And so when you look at, what type of breast cancers are caught by mammograms, a lot of times it's the early stage, DCIS. About 25% of breast cancers detected by mammograms are DCIS, and that is a very early stage ductal carcinoma in situ. It can become invasive, but doctors have a difficult time determining if DCIS when it's really what's it called? Not invasive yet. It's like just in the duct and isolated there. It's hard for them to know if it's going to end up becoming invasive. So we'll talk about that a little bit more. But the mammograms tend to catch things in fatty tissue, fatty breast tissue, fibrocystic tissue, slow growing tumors. And so, like with any type of screening, we have to know what the strengths and weaknesses are. So these are some of the things that, mammogram does a better job at. Now, we have to talk about the cons as well. So let me hide that. Okay, good. Some of the limitations. Okay, this is something that I think really goes overlooked in the whole conversation around mammograms. Really, a lot of times women want us to boil down the conversation to what test should I get done? Should I get a mammogram? Should I get an ultrasound? And a lot of people will say, get the mammogram. It's early detection. It's the gold standard. And they just kind of have these blanket statements that they say with mammograms. And while I recognize that it's a very valid test, we have to balance it out with having a full conversation about the downsides. So the downsides are, dense breast tissue. If you haven't heard about breast density, it's very important for women to understand because not only does it increase your risk for developing breast cancer more so than family history, it also decreases the accuracy of a mammogram. So you're more likely to have a false positive where you don't have breast cancer, but a mammogram is suspicious. And you're also more likely to have a false negative where you have breast cancer and mammogram says that everything is fine. So, on top of that, the radiation exposure is not equal across all breast types. So, unfortunately, women with large breasts and women with dense breasts absorb more radiation than women with smaller or fatty breast tissue. So, when we talk about the potential harms of the radiation exposure, it's not equal for everyone. And I know the analogy oftentimes is like, oh, it's like going across the United States in an airplane. Unfortunately, that's not really apples and oranges because that's looking at the radiation exposure that is diffusely, spread out across the whole body during that flight. And the mammogram is that amount, but it's concentrated down to targeting just that breast tissue. So it's not the same. And there's concern for women, particularly with the BRCA gene mutations. They have a higher risk of developing breast cancer. And unfortunately, they have a harder time repairing cells that have mutated from DNA damage, and radiation causes that. And so there's a greater concern around radiation exposure to BRCA gene positive patients. Unfortunately, those patients are the ones that are encouraged to start mammograms younger and more frequently. So we have this kind of conundrum of that situation going on. Another limitation would be breast implants. They do have a maneuver where they basically shove the implant out of the way for certain images so that they don't miss a very significant portion of the breast tissue. If they don't do that, and it can be very uncomfortable, if they don't do that, they really run a higher risk of missing breast cancer that the implant is covering up. Um, of course, there's also like the potential for damaging the breast implants. We had a patient where that had happened to her twice, and she said, Rebecca, I cannot afford to have them replaced a third time because every time I have to pay to have this whole new surgery done. So it's a valid concern. The other issue can be if a woman is very small chested or she's had a mastectomy. It's not necessarily a great option, and it's not even recommended for women who have had mastectomy. Women who have had mastectomy, they're just basically told they don't need to have any screening done, which concerns me because they still have axillary lymph nodes, they still have the potential for recurrence on the chest wall. So in those situations, they might want to consider MRI, ultrasound, thermography, something like that. It's just difficult with mammograms because it has to go between those two plates. Large breasts can be difficult to image the entire breast tissue, and then breastfeeding, it should be contraindicated because of the radiation exposure. I'm sorry, for pregnant, not breastfeeding, pregnant women. And then younger patients, it can be more harmful. So they said they've looked at the research of the risk to benefit ratio. Women who are younger tend to have more downsides to screening mammograms versus the benefit that it brings. So, and some of that has to do with the breast density and the radiation exposure. The younger you are with radiation exposure, the more likely it is to cause problems. The chest wall can be difficult to visualize. It's not impossible. These aren't impossible to see on the mammogram. It's just a little bit more difficult to visualize. And then the trying to tell between like a solid lump and a fluid-filled lump is difficult on a mammogram. So oftentimes if you have lumpy, bumpy breasts, like a lot of women do, that's totally normal, but it can be like very frustrating because you can go get the mammogram and then they're worried about a lump, and then they go and have the ultrasound to see if it's a cyst or if it's solid, and then they're like, oh, it's just a cyst. And it can be very frustrating for women to have to go through some extra hoops like that. The ionizing radiation, there is research that calculates how many breast cancers are caused by screening mammograms, and they found that essentially 125 breast cancers are induced per 100,000 women screened. And, this is smaller, much smaller than what they estimate the lives saved. So they estimated 900 and something, breast cancer deaths averted. And so I understand that they kind of justify it, right? Because they're like, overall, we're saving lives. And I completely understand that standpoint. However, we also have to recognize that it does cause harm. And there are a lot of tools, in my opinion, that are underutilized for saving lives and, helping those 900 and something women avoid death without causing the 125 to have cancer. So I I think that's something that's worth talking about. Um, and again, it's not to completely throw away mammograms as a tool, but that same study talked about how starting mammograms, every other year instead of every year, that helped reduce some of the harms. I've seen other studies where they suggest every 3 years doing a mammogram to reduce the um, overdiagnosis and the harms without lowering the lives saved and the detection and everything. So I think there's good conversation that could be had around how often we use mammograms, and the age groups, because it really varies a lot on kind of the pros and cons conversation. And the other thing is that, we don't really talk about the possible harm of the pressure applied. So, for women with large breasts or with dense breasts, they can have a lot of pressure applied. Unfortunately, they've shown where tumors can um, have cellular like spread into surrounding tissue and circulation from certain amounts of pressure, and mammograms are higher pressure than that. And so while it's not like every single time this happens, when you have a mammogram, then it's going to cause it to spread, that's certainly not what I'm saying. But there is that risk factor that research has discussed as something to consider. Um, the other thing is really the whole purpose of breast screening in general. Most people think that the earlier the better, the smaller the better. While that's true in some sense, there is this gray area where we see DCIS stage 0 breast cancer. If it's stage 0, which, some people are like, I've never heard of stage 0. What is that? Um, it's essentially where it's so small and isolated and contained, it's not invasive yet. And really, cancer cannot cause harm until it's invasive. So there is controversy over whether or not, you know, patients should be treated as if they have cancer, um, when it's just so early. And then you have like a lot of the downsides of the radiation treatment or the hormone blocker medication that you can be put on, even for stage 0 situations. Again, I had a patient where she had stage 0 and they were like, you can have a double mastectomy, you can have this, you can have that. You definitely need, radiation and a hormone blocking medication. And, you know, those aren't without health impacts. So these women can be put in a position where they have something that may become invasive. We don't know. Um, and most people are just terrified because they hear that word cancer and they think that they're going to die, and it's, something that could kill them. And that's the confusing part with the stage 0 is, are we actually causing more health problems for these women that may not have been necessary? And I know that's a very difficult concept to think about. Um, but there are ways to monitor. And some women find that, they want to watch stage 0 and work on their health and, basically see if that's something that ever becomes a problem and then addressing it from there. So it's a big concern. And 25% of mammograms, or 25% of breast cancers that are found by mammograms, are DCIS. And so a lot of women out there, that are harping on getting mammograms, go get your mammograms. It saved my life. Um, you know, sometimes it's like it does save some lives, but some women feel it saved their life when, was it stage 0? I don't know. I don't know if that's, really the full situation there. Um, so those are a lot of the controversies. And then with the Sweden um, studies and meta-analysis, they didn't see the mortality rate reduction that a lot of the US talks about, where mammograms are saving lives and lowering breast cancer death rates. Um, there's definitely a lot of controversy around whether that's true and whether the harms outweigh the benefits. There's other countries that basically disagree, and they feel that mammograms cause more harm than benefit overall. Now, that's not on an individual level, because there could certainly be women who have an aggressive cancer that was found by a mammogram, but overall, the big numbers in a population view, they were saying that it's not actually lowering the death rate, but it's actually more so the breast cancer treatments that have improved over the years, lowering the death rate more so than the mammogram screening. So there's a lot of different factors. It can be very confusing. And one of the things that I saw in research is where they talk about women who didn't have mammogram screening had about 5% chance of dying from breast cancer, and then with mammograms it went down to 4%. And this sounds like a small amount, and they in the research they look at 5% as if that's 100%, and so going down to 4%, they were calling it a 20% reduction. So that's where like percentages and statistics can be a little misleading. And I'm not saying that that's not true, because that is actually a 20% reduction if you're going from 5% to 4%. But in the big scheme of things, of 100%, chance going from 5 to 4, that's just a different perspective of the same numbers. So you kind of, again, have to think through the big picture and what these numbers are actually saying, instead of what they kind of almost inflate in a way. I know that was a big topic. Sorry, it was like a very long slide to get through. Thanks for bearing with me. Um, so one of the things that I wanted to touch on when we talked about the dense breasts here and how mammograms miss 35 to 52. Now, this is one study. I have seen studies where it misses, 60 to 70%. So it varies, and it's very concerning, because this is kind of a gracious view of that. It can be worse, depending on which study you're looking at. And it's not a rare thing. Women with dense breasts is 50% of women. Now, when you're younger, in your 30s and 40s, it's closer to like 70 to 75% of women. And when you're over 50 and in your 50s and 60s and 70s, then it goes, lower amount. Not always. So it doesn't change. So women who are premenopause, they tend to have more dense breast tissue. And then after menopause, some women can have their density decrease after their hormones calm down. But in some women, that still remains. And so we have women who are in their 70s who have extremely dense breast tissue. This also doesn't relate to breast size. So you can be small chested, you can be large chested. And so it's difficult for women to know if they have dense breast tissue unless they've had a mammogram done. Now, you can kind of tell on an ultrasound if a woman has dense breast tissue based on how the images look. But as far as like grading your specific, grade level, your category of density, that is done by a mammogram. So when a woman has fatty tissue or fibrocystic tissue, they're going to have a different detection rate for breast cancer by a mammogram. And then when you have heterogeneously dense or extremely dense tissue, you're going to have a lower detection rate by a mammogram. So, again, with the conversations that people have online and, with their doctors, a lot of times people are making very big general statements. And that's one of the biggest things that I want to impress on this presentation is that we cannot be giving generalized, statements about breast screening because it is individual to that patient. And we really need to advocate for patient-centric recommendations instead of just, a general protocol. So here's an example because a lot of times people say, well, 3D mammogram is, great for dense breasts, so we don't need to worry about it. This is comparing 3D mammogram versus an MRI. And women who had the heterogeneously dense or extremely dense, which is 50% of women, MRI was able to detect all of the invasive cancers and about 5 out of 6 DCIS. So in contrast, the 3D mammograms detected 7 out of 17 of the invasive cancers and about 2 out of 6 of the DCIS. So, again, I'm not trying to like throw mammograms out completely, but we need to have honest conversations about the limitations that they have and the variables and variety of detection rates that can happen that, we really like, unfortunately, as the healthcare system has really put their trust in mammograms. And thankfully, over the years, we've had a lot of people advocating about this dense breast issue. In particular, there was a woman who had dense breasts and her cancer was missed, and she started kind of a grassroots movement and lobbied to all these different states pushing legislation to tell women if they have dense breasts because it's such a big factor for mammogram screening. And prior to all of her work, there was no conversation. There was no admittance about dense breast tissue affecting mammograms. And so thank goodness for her hard work making this happen for over years of work. And I think she's since passed away. I think the organization that she started was rudense.org. And thankfully now it's a federal law. So all 50 states finally are required to basically inform patients if they have dense breasts. Now, they don't fully explain, unfortunately, what all that means, but at least they're mentioning it. So we still have more ways to go. And I'm just now seeing that some people couldn't hear the live, so I hope that people can hear me. I thought I had checked all of that, but yeah, so hopefully that's all recorded. So with thermography, we have a lot of pros with thermography. We do have some cons, and that's literally with any imaging tool. So the pros on this one, there's no radiation, there's no compression, there's no contact with the body, there's no contrast. It does find inflammatory breast cancer, which I didn't mention on the mammogram side because there's just so much to talk about. But inflammatory breast cancer spreads through the skin, and so doesn't form a lump. Another type of cancer that is difficult to detect would be like a triple negative breast cancer. It's more aggressive, and those are more likely to be missed on a mammogram. And a lobular carcinoma. So lobular is basically kind of more spread out in the breast tissue, and it's not as formed as like a solid classic looking lump. So thankfully, we don't really have those types of cancers don't negatively affect the detection rate of thermography. So it's not impacted by breast density. It's not really impacted by lobular or DCIS or triple negative. It has a very good predictive value. Now, this is where what I mean by predictive value is that when we have suspicious thermography scans at least once or multiple times, where it's like, this doesn't look overtly suspicious, but this looks a little abnormal on your thermography scan, it's more likely for that woman to develop breast cancer within a handful of years. So that was one of the biggest problems with research on thermography, was that it was basically causing an alarm, right? Of saying, hey, something's off here. They would do the mammogram and the ultrasound, and they'd say, thermography is just being over dramatic, too many false positives. This patient doesn't have breast cancer. But what they found in retrospective studies was that those patients, a large portion of those patients, went on to develop breast cancer. So it has a really good predictive value. It also tends to catch aggressive tumors, because when you think about how it's looking at inflammation and blood flow and metabolic rate, metabolic activity, the more faster growing tumors have more metabolic rate and more blood flow required. And so a lot of times those are the ones we're more likely to spot. And then in research, in looking at thermography versus mammograms, thermography was an earlier alarm in 60% of the breast cancers that were caught. It's also really breast health focused. I think that's an important distinction to make, because all of the other breast imaging tools we have, all of them are looking for breast cancer. And one of the things I'm passionate about is helping women learn more about their health, be more proactive, be more preventive, lower their inflammation, balance their hormones, increase their detoxification rate, and reduce their risk of developing breast cancer. So I think that's a very, very valuable part of thermography. And that goes into the next point there, and it's great for women under 50. So again, with the downsides of younger women with mammograms and how it tends to have more false positives, more false negatives, more radiation harms in younger women, that's not a factor for thermography. So I love thermography for younger women. I typically recommend starting in their late 20s or early 30s. We have unfortunately found breast cancer in women in their 30s, and so we know that breast cancer takes years to develop, and so we want to start at a young enough age to catch it as soon as possible and hopefully have a role in prevention. Let me see if someone's having a difficult time hearing, but Ashley said she can hear it, so I think we're good. So the thermography cons, okay, it's not widely accepted. It's not covered by insurance. A lot of doctors will send them a copy of the results, or the patient will show them the results, and they'll say, I don't know how to read this. And which I find funny, because the thermologist has already done the interpretation for them and written out a report. All they need to do is read the report. They can also call our office if they need clarification on the report part of it. So, but a lot of doctors just kind of push it to the side because they're not familiar with it. It's not covered by insurance. A lot of times they view that as something, I would say, hokey pokey if it's not covered by insurance. And it's a really sad issue, because they're missing out big time, and so are their patients. There's a wide mix of studies it is a hot mess when you look at the thermography research, because there are research studies that were poorly done way back in the day before the technology was more advanced. And so a lot of times they're looking at things that are poor quality studies in the mix, and they basically say, oh, we don't see consistency, so we're not going to trust this tool. So that's been a big problem. And then for patients who are obese, I will say there's a little bit of a chance that basically there's more tissue there. So there might be more of a risk of missing something in an obese patient. There might be something like more risk of missing something for a woman who's had a ton of breast surgeries, like multiple reductions, implants, explants, a lot of surgeries. Now that's kind of difficult for mammograms and ultrasound and like all the imaging tools, because there's a lot of scar tissue in there. There's a lot of like lesions from those procedures. So I do like to point out that those are situations where I think it might be better for us to pair the thermography with a structural imaging scan like an ultrasound, just to kind of be on the safe side and make sure we're not missing anything between those two tools. Radiation to the breast, when we have patients who've had cancer treatment with radiation, it does leave a lot of like long-term inflammation in that area. So I do feel like, just thinking logically, like it will be a little bit more difficult for us to see inflammation in that area because there's already radiation inflammation there. So in that case, it's like, well, this would be good to do this and an ultrasound and get a little bit more of a comprehensive evaluation from a couple different perspectives. The breast cancers that are more likely to be missed would be like a really slow growing tumor, one that is basically like that stage 0 where there's nothing, it's not invasive, it's just kind of like isolated and sitting there not doing anything. And then in older patients, they have a much slower metabolic rate and less vascularity in the breast tissue, so they're more likely. It doesn't mean we're not going to see these things. It's just as far as the risk level of missing it does increase with these scenarios. It doesn't give any structural information, and that can be very confusing to people because they're like, hey, do you see my metal clip from my biopsy? Or do you see this cyst? Or do you see this lump that I have? And that's not at all what thermography is looking at. Thermography is a screening tool that looks at the inflammation and the blood flow only and the lymph congestion. And so it doesn't tell us anything about structural. And that can be a pro in some situations where we have some women who have literally hundreds of cysts and lumps. And so when they get structural imaging, it's really difficult for them to assess that breast tissue. Whereas with us, with thermography, we're not overly confused or basically it's like unless we have abnormal blood flow to one of those lumps, we don't see any reason to be concerned. And so for some women that are so tired of being called back every single time they go get a mammogram, they have to come back for more imaging, the lumpy bumpy girls out there, this is a really nice option because we're not negatively impacted by that. We only see if there's like abnormal blood flow or inflammation. And so in some ways that can be a con, and in other ways that can be a pro. But all that being said, this is one of the key reasons why thermography cannot be used for all scenarios. And like it's basically a good step 1 for screening, because if we see something abnormal, we have to get some structural information. You know, some women come in for a thermography scan and they get upset because they have abnormal results and they have to go get some kind of structural imaging, and they're like, well, I wanted to do this instead of that. And the real purpose is to reduce the need for more invasive testing when we can, but to also to see if there's anything worth investigating. So when we see something worth investigating, obviously, the next step needs to be done. And so I think that's kind of a confusing aspect for some women to think like, well, I did the thermography, so I didn't have to do a mammogram. So we understand that frustration, but really it's complementary and it's a really, really valuable tool, even though it's not going to be used by like a breast surgeon to do a biopsy because it's not looking at the structure. So it has to be followed up with structural imaging if there's something that looks suspicious so that we can see, okay, this abnormal activity, is it just a fibroadenoma? Is there a cyst? Is there something suspicious? And do we need to move forward with something like a biopsy? So the other downside to thermography that I wanted to mention on here is inappropriate claims. I've seen people who say, that it can see cancer cells circulating, and I'm like, that's a wild claim. I don't know where that came from. So people will come to us wanting this instead of a PET scan. So, there's a lot of misunderstanding out there on the appropriate application of thermography, what it can do and what it can't do. And I find that because of that misunderstanding and kind of hyping the technology more than what's appropriate, then it's more likely to be dismissed by a lot of people because they see that that's not true and they dismiss it as a whole. And so that's really unfortunate. So here's an example of like tons of different research studies on the sensitivity of thermography and all of the different outcomes. And so you can see some of these studies have lower sensitivity rates, but by and large, they, for the most part, has a really good sensitivity rate at 89%. So again, this is where it depends on what research you're looking at, what the quality of the research, and this study I looked at, I thought it was really, really well done. They sorted through a lot of the poor quality studies and focused on the ones that were done correctly, in my opinion. And some of this variety can be from studies where they're looking at the grade level. So there's different grade levels of concern. Some studies include grade level TH3 through TH5, and other studies were only including TH4 and 5. So there's a difference in what they considered abnormal on the thermography, and that affected how much breast cancer was detected based on those parameters. So a lot of that is the confusion around thermography research. Ultrasounds, there's no radiation or contrast. There's no compression, like strong compression that's risky. They're more likely to find smaller cancers. They are safe for pregnant or breastfeeding. It's accurate for that. And it increases detection, especially in dense breasts. It can distinguish between a solid mass and a cyst. So more suspicious lumps versus benign lumps. And it's not impacted by age, so young women can benefit as well. Now, the downsides is that it depends on the technician's skill level. So there is, again, variety in the detection rate depending on the quality of the technicians and radiologists. That's why at our office, we're very picky about hiring sonographers that specifically specialize in breast, and they have years of experience. They're not like new to this world, and they do really, really well. It does miss microcalcifications. So the DCIS, some of the cancers that are microcalcification patterns can be missed. Large breasts can be difficult to image, and I feel like this is kind of a common factor for all of the breast imaging. Larger breasts can be difficult across the board. It doesn't mean that, we don't do a good job, but it's just there's a little bit more likely chance of missing something, unfortunately. And it's not covered by insurance unless you've had a mammogram first, so it's a little less accessible. and it's less likely to find DCIS versus invasive cancer. Now, when you're talking about the controversy around over-diagnosis and over-treatment, this could be a pro and a con. Again, because some women with DCIS would never have died from that breast cancer. They would have died from something else by the time it ever became invasive. And again, we can't know that on an individual level. So we just treat women for cancer across the board regardless. And, that's something that is still needing to be sorted out. And we're hoping to develop technology that can tell us which ones will become invasive or not. And we just don't know that now. So with sensitivity and specificity, before I go to the next slide where I'm talking about the sensitivity and specificity, I wanted to point out what it means. So this is referring to how many patients with a positive finding, like it comes back suspicious, how many actually have the disease. And so the more breast cancers that are missed, you're going to see lower sensitivity. Now with specificity, this is kind of the flip side of the coin where it relates to how many patients with negative findings truly don't have the disease. So the more false positive results where patients have abnormal results but no breast cancer, you're going to see lower specificity. So this is like the one where women get really frustrated because they're like, oh, I was worried over nothing. This is just total crap. I hate this type of technology. I feel like that happens with any type of screening. And the same thing happens here where breast cancers can be missed by any type of screening. You're not going to see 100% for any type of imaging tool. And so what we find a lot of times is that the higher the sensitivity, the more an imaging tool can find breast cancer, generally it can also lower the specificity. So the more positive findings, the more breast cancer found, a lot of times the more women who don't have breast cancer have like a false alarm. So it's a constant balancing act in the screening industry world where we want to find breast cancer, but we don't want to stress out women who don't have it. And, that is a constant battle with breast imaging in general. So just having an understanding for that and knowing that that's part of the process, unfortunately, part of the reality, can help you have a little bit more realistic or a little bit more grace when maybe something comes back concerning and it ends up being nothing. It's because that tool's probably catching more breast cancers. It's really difficult to have perfect on both sides of that coin. So with mammograms, I wanted to make this chart so that it could be really clear cut on the pros and cons. And as you can see, there are so many different factors to consider. And even when you're looking at the research for sensitivity and specificity, it varies depending on the age group. It depends on the type of breast cancer. It depends on the size of the breast cancer. So you're going to see a lot of variety, and I did my absolute best to look at meta-analyses and ways where they're looking at a large group of individual studies and compounding the information to basically an average. So the detection rate on average for mammograms varies widely because of the density issue. For thermography, over all of these different studies that I showed you back here on this chart here, it's 89% detection rate. For ultrasound, it's about 76, and this does really well with dense tissue. So that's where like this dense tissue going down to 30 to 50% for mammograms. Ultrasound at 76 is quite a good compromise for that. So then for specificity, this is when we have the false alarms. So for mammograms, about 30% of 30% of mammograms are going to be like a false alarm, unfortunately. With thermography, we have a good amount of false alarms as well. Ultrasound is going to be 88% specificity, so that means 12% false alarm. And that, again, this varies depending on what research you're looking at. And then with MRI, you have a smaller amount of false alarms at like, 19 to 2% of false alarms. So MRI is definitely the higher detection and specificity rate across the board. However, the downside is that this is with contrast. So MRI with contrast is unfortunately very harmful because of the gadolinium. Um, and we actually had a radiologist in our office. She was like a co-owner of a hospital and head of the radiology department. Very, very, very smart cookie. And she was adamant about not doing MRIs with contrast unless it was very necessary, unless it was something truly concerning that would warrant that contrast. So as a screening tool, one, it's really expensive, which, that's just one factor. But the downside to me is the contrast, unfortunately, which helps to highlight the vascularity in the breast tissue and makes it more accurate. Without the contrast, we're not going to see this level of detection rate, unfortunately. So then you can see, what's effective for younger women, implants, calcifications, if you can see whether it's a solid lump or a cyst, if it's good during pregnancy or breastfeeding. It's safe. Thermography is safe for this period of time, but it's not accurate for the breast region. So we've had some patients who are doing full body scans during pregnancy or breastfeeding, and we just let the doctor know that those areas are not going to be read properly. And then I did mention risk of overdiagnosis here because I think while there's not as much research on this for thermography or ultrasound, there's definitely a lot of talk about that for mammograms and MRI. So it is something to consider. QT imaging is something that is new on the market. One of the pros, now this is like basically kind of like an ultrasound technology. It's called transmission ultrasound, and it's got some amazing pros to it. And it can, reduce the unnecessary callbacks for benign findings like ultrasound does, and but maybe even more than ultrasound. Unfortunately, the research is like so little at this point that it's really hard to know all of the ins and outs of this thing. It is more detailed. It's more similar to like a 3D mammogram or an MRI. It's very detailed. It's great with dense breast tissue, and it's really good at measuring the volume of masses. So while ultrasound could see a suspicious tumor, it might not show like the entire perfectly measured size of it, whereas a QT and an MRI, both of those are more accurate at showing the full volume of a mass. And so when you're talking with a surgeon, for example, um, at that point you want to have that surgeon be able to know what kind of surgery they need to do. So I find that this is, more important later on in the scheme of things when you see something on a thermography or an ultrasound that's suspicious and you need to be considering biopsy or surgery, then an MRI or a QT would be a little bit more accurate in determining the full size of it. But as far as like a screening tool, I don't have enough research. It's really small studies. It's very limited information. I don't know how much it increases with like the overdiagnosis concern of that part of it. It did reduce the unnecessary callbacks, but in that same study, it's slightly lowered the callback for women who actually did have breast cancer by 2%. So again, I think that there's still a lot that we need to learn about this before I can feel confident in what it's truly adding, pros and cons wise, in the big scheme of things. So that one is kind of, we'll see. And unfortunately, the person who's sharing a lot of the information online, she owns all the, not all of them, but she owns a lot of the imaging centers for QT imaging. And so I don't know if there's some bias in the way she words things. I prefer to look at actual research, with broad scale, large groups over a long period of time before we really make big calls about this, because I did see the same thing happen with 3D mammograms, where a lot of big assumptions were around 3D mammograms before they had big research on it. And we've seen now that the bigger research is out on 3D mammograms, it's not as amazing as they made it sound. So that's one of my concerns. And then with MRIs, we talked about the contrast. It should be used sparingly. It can increase false positives because remember, more sensitivity sometimes can be more false positives. An MRI without contrast is an option, but it's not going to be as accurate. It still misses masses that are under a centimeter in size. It's still difficult to access. And so one of the popular MRI without contrast options is the Prenuvo scan. And this is a really, really cool MRI that doesn't have contrast. It's amazing. It shows a ton of different things on a scan, but it still doesn't replace endoscopy, colonoscopy, breast imaging, pap smear, dermatological issues. It still, has to see something a centimeter or larger. So small masses can be missed, and it doesn't check the heart, the lung for micronodules, lymph, inflammation, different things like that, bowel polyps. So there's a lot, I think, that, in the fine print on their website that they talk about them not seeing. As long as people know like what they're getting out of scans and what they're not getting, I think it's fine. But it's just, I do feel like the Prenuvo scan can be like overhyped as well, as far as, it basically checking for everything, and that's not necessarily true. So I just wanted to point out the things that you need to know are not included. I think that's important. Fluid tests, there are certain blood tests that are called like a liquid biopsy. I've listed some of the labs here for you to look into. And, there's varying specificity and sensitivity with all of these. So I think that's important to look into. The tear test, which is the ARIA tear test, screens for breast cancer, which is really cool. You can do it at home, but they have inflated the sensitivity to catch more breast cancers, and that means that their specificity went down. And so a lot of times women will have false positive results. And the other important thing that is critical, in my opinion, to understand is that it tends to catch smaller tumors. It tends to miss tumors where there's multiple breast tumors or where metastasis to a node has occurred. So that's really important because women with more aggressive invasive cancers were being missed by the tear test. So that's concerning to me. I feel like, yes, this is helpful, but at the end of the day, I think we have other tools that are going to be more reliable. And then this one, you can see that when they upped the sensitivity to 90%, specificity went to 34%. So it's a very big issue, in my opinion, with that. So I know I covered a ton of information on this. This is our contact information. If you have any more questions about breast imaging and the pros and cons, I think this is a really, really important topic. And I know I went a little over on the time, but it was a lot of information to cover. And I hope that this really helped give you a sense of really truly like the pros and cons and what would be the most appropriate for your situation if you're a younger woman or if you have dense breast tissue or if you have implants or all the different scenarios. Patients have a wide variety of scenarios going on. And so I think as clinicians and practitioners, especially, we need to know all of the ins and outs on those things. And so hopefully, at least for yourself, you can now maybe be a little bit more in the know on what would be the best fit for you. And we offer thermography and ultrasound. I think that's an incredible combination of screening, because we can see earlier signs of issues going on in the breast tissue with thermography, and then we can get the structural piece of it with the ultrasound and see if there's, something more like a cyst or something that's more suspicious. And I've found that that's been a really, really amazing combination. So, again, if you have any questions or need anything, this is our information. So reach out anytime, and I hope this was good for you. I'm going to go ahead and stop the live. Thanks so much.